In some ways, it's like Charles Dickens. It was the best of times and it was the worst of times. When you look overall at children with ALL, the outcomes are outstanding. However, if it is your son or daughter who is not cured today, that doesn't mean a lot to you. And still, ALL is one of the leading causes of death from cancer in children. So I think we have several challenges. One is to improve outcome for patients who are not cured today. The second is we are identifying, ultra low risk groups who have survival rates in excess of 95%. In a recent paper, we showed approaching 98 to 99%, and other groups can identify these patients too. And we need to find ways to treat them less intensively and still maintain great outcomes. So I think the biggest excitement today surrounds newer immunotherapies, specifically Blinatumomab, Inotuzumab, and chimeric antigen receptor or CAR T cells, and how all of these agents are very effective in patients with relapsed and refractory ALL. And I think a key lesson from my perspective is if something works in patients who have failed other therapies, then we need to get it into frontline therapy. We shouldn't wait till you've relapsed multiple times, especially for agents like Blinatumomab and Inotuzumab, which have relatively limited toxicities compared to standard chemotherapy agents. So a lot of the movement within the Children's Oncology group and other groups worldwide is seeing, how do we add these drugs into standard therapy backbones to improve outcome? I think one of the things we're not doing as much of as we need to is to ask if we can use these new drugs to replace noxious parts of current chemotherapy regimens. Within the COG, we are trying that for children with Down syndrome, but in other settings, we're layering them on existing chemotherapy. So I think a challenge for the future, as is actually being done in older adults with Ph-positive ALL, that I talked about earlier, is can you use immunotherapies to replace parts of therapy? And that would be very exciting if we're able to do that. We are incredibly indebted to the patients and families who decide to participate in clinical trials and childhood leukemia worldwide and other childhood cancers. That's the majority of patients. And what we learn from them improves outcomes for future children, and our outcomes today are as good as they are because of children and parents who decided to participate in clinical trials 10 and 20 years ago. So we need to remember the key part they play in research advances.